we are organizing at the AKISA building of the University of Athens. This is organized by the University Department of Vascular Surgery in Athens. And we organize it for two reasons. One, to honor my predecessor, Professor Liapis, who is in the audience. And would also like to use the opportunity to thank the Association of Greek Ship Owners for donations to my department that has greatly facilitated our work. I would like to thank particularly our speakers who have generously given their time from various parts of Europe, from Russia, from France, Germany, United Kingdom, and also our sponsors who have contributed to this meeting, and that gave us the opportunity to hold this meeting free of charge to those who are interested. Now, since this meeting is partly organized to honor the contribution of Professor Liapis, who has been the foundation professor of vascular surgery in Athens, I would like to show you some pictures that highlight his achievements in life. To share screen. I'll share. I found it. All right. And where is it? Okay. Good. Okay. That's great. Oh, no. We'll have to go from the beginning. How can we start from the beginning? Yes. I'll probably proceed from the beginning. Good. Lovely. So Professor Liapis comes from a scenic part of Greece. He comes from Kalabaka in Meteora. You can see the landscape that is really spectacular. And here I'm showing you his parents. Take a look at his dad. He inspires confidence. And his mom, who is in full harmony with his father. Professor Liapis did his training in general surgery with some of the most prominent Greek professors of his time. You can see on the left, professor in the inset, Professor Skalkeas, who has been one of the fathers of general surgery in Athens, and at some time he was president of the Academy of Athens. And then you see Professor Sechas and Professor Bubbas, who both have been pioneering vascular surgery in Greece a few decades ago. And Professor Liapis, when he finished his training in Athens, he moved on to the United States. And one of the most prominent institutions at the time for vascular surgery was the Ohio State University Hospital in Columbus. And at that time, one of the most well-known vascular surgeons was Professor Evans. He was organizing a famous symposium in the United States before the time of Frank Leith, and he was quite well known for his contribution to vascular surgery and to educational meetings in vascular surgery. You also see some other key figures in vascular surgery who were associated with the training of Professor Liapis in the United States, like Professor Stoney, Professor Baker in Chicago, Professor Bergen. And but Professor Liapis has, when he returned back to Greece, he was not confined only in academic surgery. He moved on widely to what was happening in the vascular scene in Europe, and he was successfully integrated with vascular consultants and vascular specialists in the European Society for Vascular Surgery. So here you can see a picture on the creation of the UEMS boards in vascular surgery, where Professor Liapis had the prominent role. As you see, Professor Greenholz, Professor Benedetti, and Hanu Halila. The next step was the creation of a vascular board in vascular surgery, and that was a major achievement. The innovation in the vascular board in vascular surgery, and Professor Liapis had an important role, was that it was not just a theoretical examination, asking questions and finding out what the trainees knew, but there was also a technical skills section where the trainees were also examined on technical skills in basic operations such as carotid endarterectomy or the dissection of the saphenofemoral junction. Here you can see a picture from the first exams of the European boards in vascular surgery, and these were held in Dublin, and that's a picture of the examiners. And you can see among the examiners Professor Liapis and some other prominent professor of his time. Professor Liapis was also distinguished in the European Society of Vascular Surgery by his election as president of the European Society of Vascular Surgery. And you can see here a picture in the presidential dinner in Helsinki at the time of his presidency. Eventually, he became professor of vascular surgery and foundation director of vascular unit in Athens. And see here the Attikon University Hospital where I work and where this meeting is being held for those who had the opportunity to attend it. He established the first university department of vascular surgery at the University of Athens. And I benefit from his excellent organization skills because he left to me an excellent unit to expand and improve, which was great. Here you can see the picture of his colleagues during the first procedure that was done at the Attikon University Hospital in 2008. But Professor Liapis did not consider that he has achieved all his goals. He was continuously creative. He moved on creating an excellent MSc course in endovascular techniques. And what was unique at his time, because that happened 11 years ago, and that has to be highlighted, is that it was not a local course in Athens. He created this course in association with the University of Bicocca, Milano, with Professor Giorgio Biasi, who was another of the important figures of the ESVS, the European Society for Vascular Surgery, during his time. So it was a joint course between Milano and Athens. And I'm pleased because I inherited this course from Professor Liapis, and I had the opportunity to make some improvements. And I'm sure my successors will do the same. And so this course is continuously improving, but the foundations were led by Professor Liapis. Here you can see the inauguration meeting of the MSc course in endovascular techniques. You can see on the left of Professor you can see Professor Biasis, who was the partner of Professor Liapis in Milan. And then on the left, you can see Professor Sechos, who was at the time a prominent Greek vascular surgeon. Eventually, the following year, the annual meeting of the European Society of Vascular Surgery took place. And you can see here one of the events Professor Liapis organized. And that was a run in the ancient theater where we had the first modern Olympic Games in 1986, and that's what 1986 exactly, 1996, wasn't it? That was a unique experience. Those who have taken part in this run in this ancient theater are shown in this picture, and it was really a unique experience. You can see myself and Professor Liapis competing. That was the only time in my life that we competed. It was very difficult, I could say. It was really a unique experience to run in this ancient place made up of marble. It's obviously restored. That's why I mentioned it for our foreign audience. That's why it looks so well preserved. It has been restored almost 100 years ago. Professor has had the opportunity to honor some of the distinguished vascular surgeons in Europe. And you can see here the ceremony where the degree of Doctor Honoris Causa was awarded to Professor Eckstein, who is one of our speakers and Director of Vascular Surgery in the University of Munich. Finally, we also produced a volume with in vascular surgery dedicated to Professor Liapis, with many international contributors from Europe, United States, and other places, from colleagues or acquaintances, Professor Liapis, where we had a summary of important issues and innovations in vascular surgery. So I want to move on with the next speaker because we have to keep the time. The next speaker is the Vice President of the Medical School of Athens, Professor Arkadopoulos. He is going to greet our meeting with a few words. Thank you.
Good morning. Thank you, Professor Geroulakos. Thank you, George, for the kind invitation to address the opening of this very important symposium. And on behalf of the administration of the medical school, the University of Athens, I would like to welcome all the distinguished colleagues, speakers, and attendees to this symposium. And I would like also to express our gratitude and congratulations to Professor Liapis for his achievements over the years, for his contribution to the development of vascular surgery in Greece, and for his educational offer to the students of our university. Thank you, Professor Liapis. And to you, George, again, congratulations for this meeting. I've seen the scientific program. It's very well organized. I've seen very distinguished colleagues from Greece and abroad. I'm sure it's going to be a very successful meeting. And congratulations for the unit, for your unit, for the vascular surgery, Department of Vascular Surgery of the University of Athens that you run here in Attikon Hospital, which over the years has contributed a lot to the education of our students and to the advancement of vascular surgery in Greece, and also has a very important international presence, and we're very grateful for that. So again, thank you, congratulations for this important symposium, and I wish you a very good success today.
Thank you, Professor Arkadopoulos, for your kind words. We really appreciate it. We'll move on with our next speaker. Professor Bubbas. He is a professor of internal medicine, and he represents the chief executive of the hospital, and he is the representative of the university in the board of trustees of the Attikon University Hospital. Professor Bubbas.
Thank you, George. I would like to thank Professor Geroulakos for the opportunity to express our gratitude to one of the founders of this hospital, Professor Liapis, whom I had the blessing of working with him for 1 or 2 years when I joined the Attikon, and also to the donors of the hospital who helped the University Hospital accomplish its role as a leading tertiary care hospital. But also, George, I would like to thank you for the particular symbolism of this meeting, of organizing this state-of-the-art meeting in the midst of the COVID pandemic. You show to everybody that life doesn't stop, although COVID has disrupted our lives, but it does not stop here. And this COVID pandemic can be the opportunity for a new start, for a better start with higher goals and higher ambitions. Thank you very much for all your contributions. And Professor Liapis, it was so great seeing you again.
Thank you, Professor Bubbas. We appreciate your presence in the inauguration of our meeting. We'll move on now with at St. Petersburg, Russia. My good friend Alexei is going to say a few words. he is very well equipped to say a few words about Professor Liapis, because when he was a young trainee and Professor Liapis was the president of the European Society of Vascular Surgery, he played some role in his education and advancement. Alexei, Professor Svetlikov is the chief vascular surgeon in St. Petersburg, and we're delighted to have him in our meeting today. Thank you very much, Alexei.
Thank you, George. Dear ladies and gentlemen, colleagues, friends, first of all, I'd like to thank organizers of this meeting, especially Professor George Gerolakos, for the kind invitation to join for a short speech. I'm very impressed with this program. I know George absolutely correct, right. Professor Liapis for many years, at least 20 years already. And always when we meet, I feel his friendship and nice attitude. And that's true that he helped me with the very timely advices when I applied for the Marco Polo Fellowship to go to the United States for a year. That has changed my professional life dramatically. And I thank him for this forever. I'm sure there are a number of people around whom he helped a lot. And we know that maybe I will repeat a little bit, but it's very important. His influential role as a Secretary General and the Treasurer of UMS Division on Board of Vascular Surgery. And I observed when I was in the European Society of Vascular Surgery, he really played a key part in the board examination. The development of the logbook and the CMA committee evaluating vascular events all over the Europe. And consequently, as a result of Liapis' efforts, together with Roger Greenlodge, Fabrizio Benetti, Valentini, vascular surgery, it's a very important achievement, was created in independent specialty section of Europe. And I remember very well in 2004 when Professor Liapis became and was elected as the president of European Society of Vascular Surgery. And at that time, he says it's a great honor and also a great responsibility. Maybe not everybody knows that he was also elected as an honorary member of European Association of Vascular Surgery and Training, elected by more than 2,000 young vascular surgeons from all over Europe. I couldn't find really what means name Liapis, but I tried to decipher every letter of this name. It consists of 6 letters, and the first letter is L. It's love. All people around him, colleagues, patients, they love him, and the next letter is I is inspire. Other 6 for guidance. He inspires everybody around him. And A is for athleticism. And George already showed that he's a fan of sport. I know he's a fan of football. And the P is peaceful. We always see his quiet, diplomatic behavior in many, many situations in the European society, in his country. It's another letter is I is impressive. His qualities, and the last one specialist is S. He's a real professional. Especially, we know him very well in carotid surgery. He was a leading for the guidelines, European Society of Vascular Surgery guidelines and carotid surgery. That's one of the most cited guidelines in Europe. And finally, I'm convinced that this meeting dedicated to Christos Liapis complex aneurysm unit will be very successful. I wish, first of all, Christos Liapis and all participants all the best today and the rest of your long, very long life. Thank you very much indeed again for invitation.
Thank you, Alexei. That was great. We'll move on, and the president of the next session, who is physically present, is Professor Georgopoulos. He works in one of the other major hospitals in Athens called Attikon Hospital. Professor Georgopoulos will take over with the rest of the meeting.
Well, good morning. It's a great honor to start this very interesting symposium. We all know that the treatment of complex aneurysms are the hottest topic in vascular surgery nowadays, and we should thank the organizing committee, Professor Geroulakos, Professor Liapis, and all the others who permit us to share experience with our prominent guests in this topic. And I chair this session with two distinguished colleagues, Dr. Maltezos from CAT Hospital and Dr. Hamagiorakis from National Cardiac Surgery Center. And now I'm giving floor straight away to the first speaker, Dr. Avgerinos, who's going to address the Valspar Aortic root procedure.
Thank you, Mr. Chairman, and thank you for the kind invitation to Professor Geroulakos to present in this symposium to honor Professor Liapis, who had the joy in my life to meet him both as a medical student about 20 years ago and from the patient side, since he operated my grandfather very, very successfully about 10 years ago. So I'm going, as a cardiac surgeon, I'm going to talk about the aortic root and the procedures of the aortic root, specifically the ones that spare the aortic valve. There's no relevant disclosures. And as aortic surgeons, we really need to tackle and have a good understanding of the anatomy of what consists the aortic root. Which is, of course, a three-dimensional complex structure, which does include the aortic annulus and pretty much the aortic valve before moving to the ST junction and the ascending aorta. So the term of the aortic root starts from the LVOT, the left ventricular outflow tract, the aortic annulus, the semilunar leaflets of the aortic valve, either if it is bicuspid or if it's tricuspid, the sinuses of Valsalva, which are part of the aorta, and it ends at the sinotubular junction, at which point the ascending aorta begins. And the aortic root is very important because it's in close proximity with the intraventricular septum, as well as the mitral leaflets, especially the anterior mitral leaflets. And as you can see here, that's the way it looks in a circular and the configuration with the trileaflet aortic valve. The advent of the transcutaneous valves, especially in the aortic position about 15 years ago, made us better understand the anatomy and the diagnostic techniques of the aortic root. especially with the echocardiogram, but more specifically with the advanced use of contrast, IV contrast-guided CT angio, in which we can have 3D representation of the aortic root and accurately measure all the relevant dimensions and to see the symmetry or asymmetry of that structure. The major indications to operate on the aortic root pathology are, of course, aneurysm, the presence of dissection, site dissection, and endocarditis of the aortic valve that does include the aortic root and the aortic annulus with the formation of an abscess. And as cardiac surgeons, like vascular surgeons, the magic number to have in our mind in surgeries of the aortic root aneurysms is 55 millimeters, with the exceptions, of course, being in patients with genetic syndromes, some familial disorders, especially connective tissue disorders like Marfan-Lowe's-Dietz, Ehlers-Danlos, and also the bicuspid valve, where the cutoff is much lower than that. Personally, I tend, after the 4 centimeter mark, we do more vigorous and more frequent diagnostic imaging, and the younger the patient, the more aggressive we are to offer surgery for these patients. In Valspar procedure, as the term specifies, is the procedures where you spare the aortic valve. So you try to exclude as much of the diseased aorta down to the root and leave intact the aortic valve. There are 2 major techniques. One is the reimplantation technique. It was introduced by Tyrone David at the University of Toronto back in 1992. And the second is the remodeling technique by Magdi Yacoub in London in 1993. The major criteria where we offer these techniques is a patient who's preferentially young, with acceptable surgical risk. We need to have good coaptation of the valve or good enough in order to repair it. We don't want to have concomitant procedures such as a mitral or bypass procedure in order not to increase significantly the cardiopulmonary bypass time. These techniques are ideal for patients with connective tissue, especially Marfan. The presence of a dissection is debatable. I would say in experienced hands, in the ideal patient, there's nothing wrong in trying it. And also the same applies for the bicuspid aortic valves. Personally, the last few years, along with many of my colleagues, we moved to the so-called Valsalva graft, which has this Valsalva configuration that represents or imitates the original anatomy of the aorta. The key differences between the 2 techniques is that the remodeling procedure preserves the movement of the aortic annulus, so physiologically is a much superior technique. However, it has high failure rates in genetic syndromes or bicuspid valves where the annulus is dilated. In older patients, the results, especially the ones with normal annulus. The reimplantation technique, the David technique, is a little more complicated, is the one that's commonly performed today. It provides stable aortic valve function in the studies that compare the 2 techniques, and it's definitely a superior option for genetic syndromes in terms of recurrence. This is the remodeling technique. So pretty much you take the either the tubular graft or the Valsalva graft, and you create 3 equal or unequal, depending on the valve symmetry, sinuses. And then you leave a 2 to 3 millimeter cuff at the aortic root, close to the annulus and close to the commissures, where you anastomose, and then you anastomose your left and right coronary bottoms. The reimplantation technique is a little different, in which the whole valve, if you imagine it, gets reimplanted, as the term implies, inside the tubular graft. And then I'm going to show you a video exactly how it looks. So the key here is to go as low as you can in the aortic root, pretty much down to the first fibers of the left ventricle. you have to remove all the tissue. You create your left and your right button. You can see the leaflets of the valve are left intact, as well as the 2 millimeter rim. You measure the height of the leaflet. Then these are the stagers that will immobilize the graft, and that's the graft. They will immobilize the graft at the level exactly of the aortic annulus. The 3 commissures are inserted inside the graft. The valve is secured in place, and this is the most important anastomotic layer. This is the hemostatic layer. So all the hemostasis of the procedure is based on this anastomotic layer between the dacron graft and the 2 millimeter rim of the aorta. And then the left button is anastomosed first, the left main coronary ostium, and then the right button with the I-cautery to excise the graft is also anastomosed. And this is how the valve looks in the end. From inside, you can see the 3 commissures have been resuspended. The valve is very symmetric with good captation of the leaflets. So that is very good results and predictable, hopefully, of a durable repair. I'm going to talk about just a few clinical cases that I had in my practice so far. First case, a young patient with a 6 centimeter aortic root with severe AI, aortic valve insufficiency with a central jet. Central jet means that the valve is very symmetric. So that patient was successfully repaired with a David procedure with a 36 straight graft, and we did not need to manipulate the cusps. However, a similar patient with an eccentric jet. Eccentric jet means that the valve is asymmetric. In these cases, we had to plicate the right cusp free margin in order to make it more symmetric and to eliminate the regurgitation, and that's the end result with the David procedure. However, not all valves can be spared. A 74-year-old male patient with an aortic root aneurysm, and when we operated, we saw some calcium, some sclerosis of the valve. This is a valve that you don't want to leave in place because this patient guaranteed will be back in a couple of years with severe aortic valve stenosis. So this patient got a combined AVR conduit valve graft. Female patient 65, severe AI. At the end of the procedure, we had still some AA. That's an unacceptable result for us because this patient will not have a durable outcome. So you just admit defeat and offer this patient an AVR and valve replacement as well with a modified dental. In sections, as I said, it's a little tricky. You need to have a super healthy young patient that can sustain a long procedure, ideally morphine patient. Usually they present with severe AF, which is not a problem. And in these cases, you can attempt valve sparing procedure just because you don't want to leave the root in place, because these patients tend to dilate the root either in the form of pseudoaneurysm or a true aneurysm. So in dissections, the valves are usually have minimal degeneration, minimal sclerosis. The nature of the AI jet, if it's eccentric or eccentric, is less of a concern because we resuspend the commissures anyway. The coronary buttons need a lot of attention to detail because they're very flappable. We've had very good results and long-term success. And of course, it's not indicated for patients who have end organ damage or cardiogenic shock. And the last few years, we have started using the so-called heart annuloplasty device. It's a ring, both for tri-leaflet and bileaflet valves, which is inserted below the level of the annulus. And we had very good results the last 2 to 3 years, and I think this is a device that is here to stay. So to conclude, the valve sparing aortic root replacement is a very well-established surgical option for the pathology of the aortic root. It is very complex. That's why it needs to be done by experienced surgeons. And there are a few different techniques in order to to improve the function of the aortic valve, even if it has a lot of insufficiency. And it's key to recognize the anatomy that affect the competency of the valve and correcting the valve in order to achieve durable repair that will hold, hopefully, for the patients, the rest of the life of the patient. Thank you very much.
Thank you very much, not only for your very informative presentation, but also for your ability to keep the time. And I would like to ask if in the audience there are questions or comments.
Yes.
Yes, please.
Thank you. Good morning, everybody. Thank you, Dr. Bubbas, for this excellent lecture. For those cases that it's not so great, would you consider Valsalva? Can you have experience with Valsalva grafts?
So, Professor, you just asked me if I have experience with the Valsalva grafts. Yes, very limited though. The usual technique I use is to take a valve and I just insert it in a graft, which is about 3 to 5 millimeters bigger, and I suture it myself. We were supposed to do in New York last year, the AATS, the first Edwards Valsalva graft, but it was right at the cancellation of the AATS with the pandemic. So I know that a few companies have started using it, especially with the Resilia valve that does not need to be preserved. It's a dry preservation. And I think that they will cut down, there will be the main stream from now on, instead of creating your own, and will cut down the time of procedure by 5 to 10 minutes. Yes, okay, Chris.
Good to see you. It's been a while. Last time probably no, this is a procedure that it's not it's all the same. But according to interview, serious. Some results of mortality. Despite our increasing experience, I'm still pretty massive for past lesions that are not being shown them. Past lesions that are extensive, it's pretty there. Or prolapse with both the passes, so stuff like that. Parameters then is practice for suboptimal. So, what would you say? What is your kind of point of not performing this procedure? Yeah, very big insufficiency or passages that extensive. The rental, that's the question you want. How do you measure the diameter of the This is a critical point of this procedure. How do you measure the diameter of the graft? Is the standard it's not described by the.
Let me repeat so they can hear it. So Professor Bubbas said that Attikon Hospital is one of the centers that performs this kind of rare for this kind of procedure in Greece. And his first question is, what's your cutoff in order to repair a highly regurgitant valve, especially if there's fenestrations or there's more than one prolapsing leaflets? I agree. To be honest, I've never tried to close a fenestration with pericardium, and the maximum prolapsing leaflets that I managed to successfully repair is one. So more than one, and actually even that I was burnt once or twice just by repairing once, and the patient came back, not even a few years, after a few months with the regurgitation. So I think the quality of the leaflet itself, you don't want to be too thick, you don't want to be too thin either. And with the fenestrations, personally, I don't have experience. I would shy away from using it. And your second question was if there's... Oh yes, how you measure it. I use a bougie, or you can use, some people use the St. Jude mechanical valve, the measuring device. But for me, that's how we used to do it in New York, just, you know, a regular bougie.
Shall we move to the next speaker and save the questions at the end? Thank you, Dr. Avgerinos. The next speaker is going to be Professor Holon, Stefan Holon, and the title of the presentation is Total Percutaneous Arch Repair and Endovascular Procedure.
Can you hear me?
Pretty good.
Oh, great. And can you see my slides?
We can.
Oh, fabulous. Thank you. It's an honor and a privilege to be here with you this morning. It's happy to see a lot of friends connected. Happy to be part of this complex aortic aneurysm symposium run by and organized by Christos Liapis department. And I'm really going to focus on the endovascular arch repair using a branched endograft. The previous speaker made a really very interesting communication. I just wanted to say I really enjoyed it very much. So I'm speaking on behalf of the Aortic Center here in Paris at my institution, combining CT surgeons and vascular surgeons and cardiologists, and we all work together, and we all look at the cases together to decide whether an open, an endo, or a hybrid procedure is the best option for the patient. Those are my usual disclosures. And recently we published this paper in the Annals of Surgery, looking at the specifically branched endografting following an acute type A open repair. So all those patients had open surgery for an acute type A and then had a branched endograft during follow-up because of false lumen evolution at the level of the arch and descending thoracic aorta. And what is interesting here is that you can see that the number of patients was quite high, 70 patients enrolled, and we obtained what I would call an unmatched in-hospital combined mortality and stroke rate of 4%. You have to realize that those patients would have required reduced anatomy, deep hypothermia, and a frozen elephant trunk repair. And usually this type of mortality and stroke rate is much higher when doing this surgery. So maybe there's a niche of patients that really truly benefit from the endovascular approach. But despite the very high technical success rate, there is an Achilles heel, and the Achilles heel is the number of secondary procedure to completely exclude flow to the false lumen. Now, what we have learned from our experience with those branched endografts in chronic dissections following an open repair, and you can see here a tube in the ascending, is that most of those patients can have a repair with a free branched endograft. So we have the usual two antegrade branches for the nominate trunk and for the left common carotid. And in addition, we have a retrograde branch to access the left subclavian artery directly from the groin. And you can see these are pictures from the book edited by Gustavo Odrich. You see the two antegrade branches going to the nominate and the left common, requiring an open carotid approach, and the retrograde access to the left subclavian branch that you connect with a very flexible bridging stent. Those are a couple of examples of such patient previously treated with an open surgery of the ascending and then an evolution of the false lumen and fixed with the implantation of branched endografts. Now, when specifically looking at those cases with free branched endograft, Emmanuel Tenorio and Gustavo Odrich run this global registry that was presented at the SVS and published in the JVS. And they look at a significant number of patients. And what you can see here is, again, as mentioned previously, there's a quite significant number of secondary intervention in those patients. And you can see that almost half of those secondary intervention are early reintervention for access complication, because remember, those patients have open carotid approach, and we use very high dose heparin during those procedures. We want to keep the ACT above 300, so a lot of swelling and a lot of patients required a secondary procedure for access issues. So this is why we decided to change the technique, and we've published, it's soon released, it's in press in Annals of Surgery, a new technique to perform those free branch endograft without using a knife, meaning without any open access. And this is what I'm going to describe now. So what has changed is we do not anymore access the right common carotid. We do a percutaneous puncture of the axillary here on the right and position two proglides in the axillary. The puncture is just out of the clavicle. At that level, you have no important branches and you have no nerves crossing. And to secure this puncture, in case that the proglide don't work, you have a 6 French sheath here in order to position a short covered stent if there's any issue. Now, the access from the groin is the usual access with a femoral access with 2 proglides for the delivery system of the endograft and with a venous access for the rapid pacing probe. Now, again, patient with a prior open repair here, access once the graft has been deployed under rapid pacing, access through the axillary sheath to the inner branch. And you can see a picture here with the two introducer sheaths at the groin level, one at the brachial level, and the other one at the axillary level. Now, what I was quoting is that once you have positioned your bridging limb and you don't need anymore this axillary access, we close the sutures of the proglide here. We usually also inflate a balloon to make sure that we have a good seal. And if for any reason we don't get a good seal, then there's always the opportunity to position a short covered stent at that level from the brachial axis. So that's for the innominate. Now for the left common carotid, what we did is we modified the preloaded catheter pathway. You can see that it goes inside the endograft through the left subclavian artery branch and usually stayed outside the graft. And now we have positioned that catheter back into the endograft lumen through the left common carotid branch. And you can see here protruding at the top. So once we are done with the innominate branch, we push a wire over this preloaded catheter, a stiff wire, and then advance a 5 French sheath all the way into the proximal endograft lumen. And inside this 5 French sheath, use a reversed taper catheter, like a shaped catheter, sorry, like a rim catheter, push a wire down into the descending, and then from the femoral sheath, snare this wire. And over this through and through wire, we advance a 10 or 12 French sheath into the ascending, and once it's in the ascending, we pull the 5 French sheath back, which brings this large sheath to first curve into the ascending and then go back into the left common carotid branch. And once we are in position with the through and through wire, everything is stable, we advance a parallel wire and catheter and access the left common carotid, and you can see then the bridging stent is advanced from the groin. So I'm going to show you various steps of the procedure, the usual wire position into the left ventricle, the tip of the delivery system through the valve, under rapid pacing, opening of the endograft. We perform those procedures under rapid pacing, under a fusion guidance, you see that once we have released the endograft, we get the nose cone and the wire out of the left ventricle. Here from the axillary axis, we are aiming at the first inner branch. Once we are inside, we shoot an angio to correctly localize the bifurcation of the innominate trunk. Then we advance the bridging limb here with a wire that has been again positioned into the left ventricle. We have a full overlap between the bridging limb and the inner branch. You see it's now opened, almost. One stent, there we are. Then we inflate the 12-millimeter balloon because this is a 12-millimeter inner branch to make sure we have a good seal and a good opening. We do a selective angio here to check that both left common carotid and axillary are patent and there's no endoleak. And then it's time to get the sheath out. So you can see here a covered stent that is implanted in the axillary to make sure that we have a good seal following the ProGlide suture closing. Now we exchange the delivery system of the endograft by a large femoral sheath, usually a 22 sheath. You see here the 5 French sheath advance over the preloaded catheter and wire. Then the reversed shape catheter, a wire is going down now into the descending, and we now have a snare here that will, you can see, grab the wire. We now have the through and through access. And over this through and through access, here I think the 10 sheath was advanced all the way into the ascending. And then we're going to use the 5 French sheath to pull that large sheath, you can see now, back into the left common carotid branch. Now that is a quite stable position. And then we push a wire and a catheter, and you see the wire actually went directly into the left common carotid, then the catheter, checking that we are in the correct vessel, and then advancing a B graft plus bridging stent. And in this patient, we had to position two stents to have to be far enough into the left common carotid to get a seal and to have a good overlap within the inner branch. And you can see the selective angio showing a nice result here. Now the 5 French sheath is now slightly retrieved, and a catheter and wire advance into the left subclavian artery. The large sheath is again advanced now into the left subclavian branch. We're checking the position of the vertebral artery and then advancing a bridging stent, which I think here was a Viaband. And you can see the Viaband has been implanted now, and we have a good seal. And this is a completion angio, 2 antegrade branches and 1 retrograde branch, and the complete exclusion here of the large arch aneurysm. And this is the post-op CT. The patient, this case was performed in January, and the patient is doing really nicely. And we've performed, I think, 10 of those since we've started using this new procedure. And we've had so far excellent results. What is impressive is how fast the patient recover because they have no opening. So they are extubated on the table, and usually only stay 1 night in the ICU to check that there's no cardiac issues. So we have a concern regarding that new approach, and the main concern is that we cannot clamp the carotids because we don't do an open approach to the carotid. So that's why we only or mostly select that approach for chronic dissection, where there's no shaggy aortical, no plaque within the aortical and supraortic trunks. And the other issue is when you come from the axillary axis, you don't have a straight path to the branch as you would from the right common carotid. So you need to position again a stiff wire in the left ventricle. Now, obviously, the benefits are that you avoid the bilateral cut downs, no neck hematoma and swelling, and we've reduced significantly the number of secondary procedure, and the workflow is very swift. Thank you very much, dear colleagues. This is what I wanted to share with you today, and I'm happy to answer any questions, if any.
Thank you, Professor Holland. Very nice presentation. Thanks for describing the innovative technique for the total arch, endovascular arch reconstruction. And now we'll move on to the, we'll save questions for the end. And we'll move on with this next presentation is Professor Bubbas, the organization of an aortic center and innovations associated with this. Is Professor Bubbas ready? Okay, I get a message here on the that he has to go to the operating soon. Shall we move on with the next presentation then, with Professor Tzilimbaris? And the title of the presentation is Cardiac Output Reduction Techniques on Endovascular Aortic Arch Repair. Is MUVIT the physiological alternative?
Yes, hello everybody. Thank you very much for the opportunity to participate in this great meeting. It would be, of course, much nicer to be in Athens with you and enjoy the nice weather instead of being in Munich. But it's a big honor, and I'm very happy to participate and to follow on the great presentation that Stefan gave with the incredible technique on the complete endovascular approach. Do you see my my screen? Okay. So the Munich Valsalva implantation technique is a technique to reduce cardiac output during TEVAR. We all know that the methods that are currently available include rapid pacing, which is the most common method used. Adenosine or drug-induced are out, as we all know, and the other option is the cava inferior occlusion with a coda balloon in the inferior cava. Each of these techniques that has certain advantages or disadvantages. I would suggest that the rapid pacing is a very good technique, but we all know there are cases where it doesn't work so good as one would expect, and there are cases where the anesthesiologists require time in order to make it work. Well, this gentleman, Dr. Valsalva, already in the 1700s came up with the Valsalva maneuver, which is just holding your nose closed and increasing the intrathoracic pressure. And what actually this brings is a compression of the heart and the large vessels, therefore a venous compression and a reduced venous return into the thoracic cavity, cardiac filling and preload, and therefore reduces the cardiac output. And you've all seen anesthesiologists perform this maneuver because it's a very regular maneuver they do to recruit lung parenchyma that has been antilactatic for some time. And a side effect of this is that the pressure drops. So we also had this observation. Actually, it was after a case of an arch repair where I was just doing some blood. I was doing some hemostasis on the neck, and I asked them to put some PEEP so we better see the venous bleedings, and we actually had a double depression. I thought, why not just do it in our case instead of doing all the complex maneuvers? So we started doing it, and it was incredible how effective it was. We were able to reduce the time that we needed for induction of anesthesia for the patient. It is less invasive than rapid pacing because you don't need extra access for this, and of course more stable than any pharmacological agents applied, which can also lead in the worst case to a cardiac arrest. We have done it in the past 2 years in 40 patients, most of them in landing zones 2 or 3 Isimarus, so distal thoracic arch, but also in patients that were done with arch branch or fenestrated going into the arch. This is the distribution: 15 branched TVARs, 3 fenestrated, and 22 standard TVARs going either all the way to the left carotid or just behind the left carotid artery. And these were the results of the maneuver. And you can appreciate we had a very high technical success of the move it maneuver. There were 2 cases where it didn't work as good as we wanted in reducing the pressure. We always set a goal of 50%, but the systolic pressure dropped in average by 55% in the cases where we were doing landing in zone 0 and 1, and 40% in the cases where we're landing in in zone 2 and 3. Here you can see it also graphically depicted with 55% reduction of systolic aortic pressure in zone 1 and 0 and 1, and 40% in 2 and 3. A big concern is, of course, what happens with the lung and what happens with the cardiovascular system in these cases. I can tell you that we had no major number of respiratory complications, at least not much more than you would usually expect in this cohort of very sick patients. No pneumothorax for sure, and we had 2 patients who had pneumonia and had to go therapy, but these were also not significant. 1 patient actually was a Gold 4 patient, COPD Gold 4 patient. She was the only one that really developed problems and unfortunately ended up dying of respiratory insufficiency about a month after the procedure. But that was also an 83-year-old patient with an acute type A dissection who was treated in a compassionate manner. So this is a case as an example of this technique, a patient with a chronic type A dissection who was previously treated with a Bentel procedure and a mechanical valve. And you can appreciate the tumor. And he also had a mechanical valve, which made the procedure even more difficult. And you can perhaps appreciate that the mechanical valve here under a fluoroscopy opening and closing, and we had to cross the valve in order to perform this procedure. So it has been suggested by Stéphane Hollon and others that we can use the system with a very rounded cone, but this is not longer produced by the company. So what we did is, together with our cardiothoracic surgeons, we decided to cross the valve, and what we did is go on the sides of the leaflets. That was successful. We have already published it previously. And here is the technique of crossing with a guide wire the mechanical valve. We went for the left side. That was not very good because of the stability. We decided to go on the other side after that. And at this point, we had access into the left ventricle in order to advance the graft. Here you can see that through the mechanical valve with the Lundquist wire in the left ventricle, we slowly and carefully, of course, advance the graft. We bring it all the way to the valve, and now the anesthesiologist starts with the Valsalva maneuver. And you will perhaps appreciate that he takes the patient into manual ventilation. He holds the patient in manual ventilation with the airway pressure going to 25, 30, sometimes even 35 millimeters of mercury. And you notice that very slowly, by constantly, the pressure goes down. And we started from 150 millimeters of mercury systolic pressure. And within 80 seconds, the pressure has gone down to 64 millimeters of mercury. And at this point, we can proceed. Here's the point, of course, where we already started the implantation. And we bring in the endograft that has passed the mechanical aortic valve, as I previously showed you. And then we deploy this, the endograft. This was a case which was not quite easy, as you could appreciate in the preoperative images. Therefore, we had to go in a very alternative way, because I was unable to cannulate the first branch from the big pseudoaneurysm that he had, which was also including the brachiocephalic trunk. So I decided to go for an alternative approach. Take the third retrograde branch for the innominate artery, the second branch for the carotid artery as it should be, and then move on with the first antegrade branch through the left subclavian artery. After this was done, we were able to finish the repair successfully. And you can here perhaps appreciate the final angiography, and the huge pseudoaneurysm is excluded, and the patient is treated with the graft very close to the mechanical aortic valve, and the aneurysm excluded in this case. So to conclude, ladies and gentlemen, I can say that so the Munich Valsalva implantation technique is a very easy and simple technique to perform. It is not as invasive as the coda balloon in the inferior, in the cava inferior, and as the pacemaker. It's cost and time saving, especially in anesthesia induction, and it includes apnea during the whole time of deployment. So you don't really have to talk to anesthesia during that time and give an order of apnea. This is automatically within the procedure. It's feasible and possible and safe, but of course you need to be very cautious in your patient selection. Success depends on experience of the anesthesiologist. You have to avoid patients with right heart disease and decompensation. And we had a bad experience with a COPD Gold 4 patient who ended up going into respiratory failure. So right now I'm trying to avoid these patients for this technique. Thank you very much for the opportunity.
Thanks, Professor Chilibaris, for this excellent presentation. Is there any question for the audience?
Can I say something?
Of course.
Yes, please.
I wanted to congratulate Nikos, because the talk, I know the beginning of the talk, but that last case was just amazing, and it shows that having this third branch for the left subclavian artery is also a bailout option for the innominate in case of previous TEVAR or open surgery, when the anatomy is not a usual anatomy. Sometimes what he showed happens is that the endograft actually rotates, and access to the branches can be really challenging. So I just want him to congratulate Nikos, and I hope that he will publish that case so that people are aware of this type of bailout option. Really fantastic, Nikos. Fabulous. Bravo.
Thank you, Stefan. I can only say the same for your presentation, which really moves us forward as you did with all the techniques that you have brought into the aortic arch. Thank you.
Any other question? Okay. Is Professor Debius with us? Is ready? Okay, then we move on the next presentation.
I very much enjoyed both the last two presentations. I was actually very much impressed with this technique for total arch replacement. We have experience with antegrade standing of the arch with the Bavarian type 1 and type 2. My questions to these excellent presenters are regarding the use of CPB. Was there any cardiopulmonary bypass available at the time of this procedure? Was a cardiac surgeon present? And particularly for the first case, where that was a complication of type A dissection, would you do the same procedure straightforward for just an aneurysm of the arch without being a complicated redo case? So again, congratulations for these new techniques. I am a little bit aware about the leak and what will be done later on. And I just want to raise the question whether in the future cardiac surgeons will have to make a redo procedure to take out the stents. But again, I was very much impressed, and hopefully this excellent technique will carry on and to be a safe procedure in the future.
So a short answer, because I really need to go to the OR. I think that my first slide, I showed you that we work in an aortic center, and we work in a hybrid room where we have a pump available. So this is not something that we do on our own, hiding from the CT surgeons. I'm actually the head of cardiac and vascular surgery. So we work together. We decide together what is the best option for each patient. And most of those cases are actually redo open surgery. And as you know, having a reduced stenotomy, deep hypothermia, circulatory arrest, and frozen elephant trunk is associated with 10-15% of stroke and mortality. So in this niche of patient, and I'm not saying that every patient can benefit from that surgery, endovascular approach, I mean, it seems that there is a benefit of doing that. So far, we've never had an open surgery after such a case, but obviously this would be very challenging. I fully agree with you, and that's why we really need to select properly our patients. It is, again, a balance between benefit and risk, and we don't have that many young patients that require that come to us for a reduced anatomy. Most of them have COPD, have a renal failure, and in those patients, obviously, it's nice to have part of the options, the endovascular options. But this is not a war between open and endo. I think both techniques should be considered, and for each patient, select the best one. And I'm sure Nikos will have interesting analysis on that. Thank you so much. I need to run. Bye-bye. Have a nice day.
Bye, Stefan.
Thank you, Professor Holon. Any other question or comment?
Well, if I could also comment on that regarding the secondary procedures and the endoleaks, I think it could become an issue because, of course, the more aggressive we become in these cases, there is the risk of endoleaks. I believe that doing an open conversion of these cases is a very high morbidity and mortality procedure for sure. but I can imagine that if that becomes necessary, there will be approaches to convert without doing a complete explantation of the graft, such as tying down the proximal neck in the ascending to make sure that you have a seal if it's a type 1A endolic, or doing an additional procedure at the or tying around the landing zones of the supraortic vessels if there's an endolic at that point. So there might be other approaches that will make also the revision, the open revision of these patients also possible.
Okay, thanks, Professor Chilibaris. I'm afraid Professor Dimopoulos is not yet connected, so we can move on to the next presentation from Professor Geroulakos, who is going to present us the comparison of open and endovascular management for juxtarenal and suprarenal aneurysms.
Chairman, ladies and gentlemen, I will try to present here a comparison of open surgical versus endovascular repair for the management of pararenal and paravisceral aortic aneurysms. This is not based on my experience, but is through a review of the literature. So pararenal abdominal aortic aneurysms include juxtarenal, suprarenal, and type 4 thoracoabdominal aneurysms. There are no randomized studies comparing open and endovascular repair for pararenal aneurysms. However, up to recently, open surgical repair, as you know, was considered the gold standard for the management of surgically fit patients. So my objective of the presentation is to summarize and present the data from studies that have directly compared endovascular and open repair for pararenal and paravisceral aneurysms. I'll start with a very interesting paper, I think one of the best that has been published only 2 years ago in the Journal of Vascular Surgery, that was a systemic review and meta-analysis of Endovenus repair versus open repair for pararenal abdominal aortic aneurysms. And this meta-analysis, as you see, included 15 studies with 5,121 patients. Out of these patients, 1,506 were endovascular and 3,615 were open. Endovascular patients were significantly older, more likely to be men, to have diabetes, coronary artery disease, and chronic kidney disease. This forest plot shows that the 30-day mortality was lower on patients who had endovascular repair. Look at the diamonds on the left of the line. In addition, the meta-analysis showed that acute renal failure was higher in patients who had open surgical repair. It was lower in patients who had an endo repair. Spinal cord ischemia, on the other hand, was lower in patients who had open surgery versus patients who had endovascular repair. As you would expect, perioperative reinterventions were more often in patients who had endovascular repair, and this is a general observation even for more simple endovascular procedures. This forest plot shows that bowel ischemia was lower in patients who had endovascular repair versus those who had open repair. Now we're moving to another study that was based in Paris. That was different from the previous one because it was a propensity match comparison of outcomes for endovascular and open surgical repair. It comes from the unit of Jean-Pierre Beckerman from Paris. And it was published in 2014, so it's a little bit old, but it's interesting. So between 2001 to 2012, 59 fevers and 324 open surgical repair patients were identified. I would like to clarify that the fevers patients were performed in Paris by Jean-Pierre Beckerman, who was very experienced, while the open surgical repair procedures were performed in Rome, in a hospital who had a high volume for this procedure, as you can see from the numbers, and they were not performing at the time endovascular repair. So there was a propensity match comparison, and patients were matched for age, gender, hypertension, congestive heart failure, coronary artery disease, stroke, COPD, diabetes, preoperative creatinine, and finally, the study consisted of 42 fevers and 147 open surgical repair patients. So there was a propensity match comparison 1 to 3. For every 1 fever, there were 3 open surgical repair patients for this comparison. The average number of vessels that were treated per patients were 2.9, let's say 3 vessels. So this univariate analysis shows that the 30-day mortality for fever was 9.5%, while for open surgical repair was 2%, and the p-value was 0.04, so that was statistically significant. And any complication was more likely to happen in the fever group rather than open surgical group, obviously because they have a higher incidence of reinterventions. And I want to mention that in this particular series, the procedural complications were more common in the fever group than an open surgical group. Finally, graft-related complications were more frequent in a fever group rather than open surgical group, and that was, again, highly statistically significant. I would like now to draw your attention to the mortality. As you've seen, and I highlighted again in my previous slide, I showed you that the high surgery volume in Rome, the perioperative mortality for these patients was 2%. However, from the Mass General Hospital, the perioperative mortality, as you see here, which is that comes from the National Surgical Quality Improvement Program in the United States, 2011-2017, and this recent publication a few months ago in the European Journal of Vascular Surgery. You see the general mortality in some of the best centers in the United States, the 30-day mortality was 6.8%. So it was much higher than the 2% that was presented in the previous paper. And particularly for the type 4 thoracoabdominal aneurysms, the mortality was 14.7%. So it's okay if we have enthusiasm who can achieve excellent results in high volume center, but these results do not represent the current practice around the world in high volume centers that have a reputation for this procedure. It is just an exception. So there is another paper here, propensity match comparison of fever with open surgical repair for Pararino and Pyrovisceral aneurysms. And this was published by the unit of Hollande when he was working in Lille. Now Hollande is not in the audience anymore, but I'll do my best to make good presentation of his results. That was published in 2018, so it's a relatively recent paper. So patients undergoing fever and open surgical repair between 2010-2016 were propensity matched for age, sex, aortic lump site, coronary artery disease, COPD, diabetes, chronic kidney disease, smoking, aneurysm diameter, and previous surgery. So it was a very good comparison, as you see, taking into account and controlling for all risk factors you could imagine. After one-to-one propensity matching, the study cohort consisted of 102 beavers and 102 open surgical repair patients. The open surgical repair patients were from a different center. It was not coming from the Lille unit. The Lille unit only contributed the fevers, but not the open surgical patients. This slide shows that the most common configuration in the fever group was 3 fenestration, with 56% of the patients. Sorry? Most common level of clumping in the surgical group was above the renal arteries, with almost 50% of the patients having the surgical clump above the renal arteries in this group of complex aneurysms. The mortality for the fever group was 2.9%, which obviously Professor Hollon should be congratulated for that. For difficult patients, he had such a low mortality, which is much lower than what was published a few years earlier from Jean-Pierre Bekemen. But that was comparable simple to the open surgical group, where the 30-day mortality was 2%. The mortality increased a little bit if we used as a factor to be considered the in-hospital mortality. The in-hospital mortality, as you would expect, increased to 3.9% for the fever group and 2.9% for the open surgical group. The other factors that were statistically significant different was the severe kidney injury, acute kidney injury. It happened in 6.9% in the endo group and 16.7% in the open surgical group. Finally, earlier interventions were more likely to occur on an endo patient rather than a patient who had surgery, open surgery. This shows that the survival after fenestrated and branched endovascular aneurysm repair was more or less the same up to 4 to 5 years than with the group who had open surgery. Then the lines deviate, but the numbers were very small, and those who had more than 5 years follow-up, so you can't come to any different conclusion to what happens after the first 5 years. This shows the freedom from re-interventions, which was favoring, obviously, open surgical repair. You see open surgical repair, if they have a good procedure that remains all right over the years, while those who had endovascular procedure, they have higher intervention and that rate, and that establishes the need for long-term follow-up for these patients over the years. Now, I would like to make a comment, as I did earlier from the Jean-Pierre Bekemen study, about the mortality in the Lille unit, which was very low, 2.9% from complex aneurysm. It's an admirable mortality. But look at these slides that I identified from different studies. The Windows is a multi-center prospective registry of fevers for complex aortic aneurysms that were treated in 8 hospitals in France between 2009 and 2012. And these are the years where Professor Hollon did his complex fevers in Lille. And look what happens. What is the picture in France? Not in isolation in the unit in Lille. So the in-hospital mortality from the 184 pararenal abdominal aortic aneurysms that were performed in France at the time Hollon presented his work was 6.5%, so 3 times higher than the unit in Lille. And the in-hospital mortality for the 42 suprarenal and type 4 thoracoabdominal aneurysms was 14.3%, which is 6 times higher than the open surgical mortality they had in the previous paper from Lille that I presented to you. So you see, you should not, some enthusiasts who present excellent results do not set up the standards widely about what is the expected mortality for the procedures they perform, because these results are not representative of a wider experience in first-class university centers in Europe and the United States. So I'm moving to another area, the cost effectiveness, which is very important when you compare open with endovascular repair, because you know that the parts we use for the endovascular repair are quite expensive. In Greece, they are much more expensive than in France. You do a beaver and fever in Greece, it could come, you could end up with a cost about 45,000 euros, which is more than twice than what they pay in France. So these results that I'm going to show you were obtained from a national hospital discharge database for both groups, the open and the endovascular group. The study was performed again by the Jean-Pierre Beckerman study in Paris, and it got the prize of the European Society of Vascular Surgery 3 years ago, and was also published in the European Journal of Vascular Surgery. So 268 high-risk patients were treated with fevers, and 1,678 average or low-risk patients were treated with open surgery in France between 2010 and 2012. The mortality did not significantly differ between these two groups, and you see again very high mortality, much higher than what was presented from Lille. The mortality for the fever group was 14.9%, and for the open surgical group, 11.8%. The 2-year hospital costs were higher in the fever group. These were 46,000 euros in the fever group versus 22,000 euros in the open surgery group. So in conclusion, Mr. Chairman, ladies and gentlemen, I think it is fair to say that preliminary evidence suggests that both techniques are equally effective. Fever is at least twice expensive as open surgical repair and has a higher intervention rate. Comparative studies on long-term outcomes and health economics on the optimal treatment of perineal aneurysms are missing and are needed. And these were the 2019 guidelines of the European Society of Vascular Surgery. I'm afraid this guideline hasn't changed and is still valid according to the meta-analysis I have shown. Finally, I would like to emphasize that I totally agree with Professor Hollon. These two techniques are complementary. They are relatively young and fit patients who will benefit from open surgery that secures a longevity over several decades and has been tested now for 50 years, while open endovascular techniques have an important role to play, particularly in patients who are not that fit or they're a little bit older and they don't have long life expectancy. And particularly in countries that they don't have the finances to sponsor expensive techniques like us in Greece. And these techniques have to be selectively performed on patients who really have a maximum benefit from that. Thank you very much.
Thank you, Professor Gerolakos, for this excellent presentation. I agree with you that the decision-making of open or endovascular procedure for this complex aneurysm is actually demanding and difficult. Is there any question or comment from the audience? Sotiris, I can't see.
I have a question for Professor Hollon. Can you hear me?
Yes. Professor Hollon, and I'm afraid
Professor Hollon
if it is something easy, I think I might be able to answer.
Professor, you were breaking off, so I couldn't. He has left the session.
Yes, he has left.
Yes,
not anymore in the audience. But Professor Bignell would like to ask me a question, so please listen.
Thank you very much. The mortality for fenestrating. And stepwise improvement time of improving it. I also wonder nice guideline when they finish recommending.
I don't think that we're ready to perform a randomized controlled study because, as you see, these techniques at the moment, they treat very, very different patients. We use fevers for patients who are really sick, and we use open surgery for relatively fit and younger patients. This is what we do in my unit. We only offer open surgery to those who are relatively fit. We don't offer them to elderly who have a lot of risk factors. I think that the scene is not mature for a randomized study. And then the cost is prohibitive. We can't offer these very expensive techniques to, there has been so much debate in England where you should offer ordinary EVAs to everybody, which is a fraction of the cost of FEVAs. When I was in England, the cost was £5,000, while in Greece, believe it or not, is 15,000, 3 times up. Unbelievable, but true. And that's multiplied by a factor of 2 for FEVAs. I think that the scene is not mature enough with this randomized study. I mean, it's all right for the academics to say it, but we're not yet ready yet. Now, regarding the second question, where we have seen an improvement in the results of fever, we have seen an improvement. As you see, Jean-Pierre Berkeman, who is an excellent surgeon, one of the most competent and pioneers in the field, he published a mortality of almost 10%. And then with Hollande, they dropped down to 2 to 3%. Jean-Pierre Berkeman in his paper commented that probably the high mortality they had comparing to open surgery was related to the fact that they were starting their experience when they performed the study. That would include their early experience. And now they have lower mortality, learning how to master these techniques.
Yes, a few, but
Professor, yes, Professor, this is great. Professor Bubbas, welcome. We're delighted to see you in our panel. Thank you very much for joining us. Yes, well, I think we'll proceed with your presentation, Professor Bubbas. It is anxiously awaited, particularly by the cardiac surgeons from Athens who are in our audience. And thank you indeed for joining us.
Thank you, George, and everybody on the panel for your kind invitation. And I am more than happy to join you, at least virtually, although I much more would love to attend in person. Let me try to show you my presentation. Is this be seen by everybody now?
Yes, of course.
Yes.
Okay, perfect. So then let me start my presentation. So the title is how to organize an aortic center and how to invent new innovations associated with aortic diseases. Well, I think to start right into the heart of the presentation, one of the main prerequisites is to have a good setting containing all medical specialties closely associated with aortic morphologies and diseases, which means the work within a cardiovascular center is of great benefit, including cardiology and, of course, heart surgery, because this connects between the specialties, allows common trainings, common innovations, and common research. Besides of this, of course, we need good technical equipment, bringing us into the opportunity to use all technical innovations which are under development. That's what we did in 2009, and we decided in October 2010 to create the German Aortic Center in Hamburg, when we brought up all these settings and setup, bringing us into the opportunity to start such a center. Besides of this, you see here my team. I think it is very important to have dedicated people who are prone to work exclusively into this field. And I had the privilege with Thilo Körbel, who was at that time a very young consultant, just trained in Malmö and I decided to let him run our aortic center. He invented, as you know, many new technologies and devices for endovascular procedures, and together with the entire team, me as his counterpart, mainly in open surgery, we were able to develop many things. We started beyond the scope of all medical universities, but 2 years later, following 2010, you see Hamburg is leading the field within the university centers of Germany, at least. Today, we perform round about 800 aortic procedures per year. But let me now go into certain interventions and innovations we were able to introduce and develop during the later years. I would like to start with the ascending aorta, which very often has a difficult access specifically for endovascular means. This brought us into the thinking to, together with our cardiologists and our heart surgeons, to use different puncture and access ways, and I specifically mean the transeptal access via the femoral vein puncture, and also the transapical access. What we, of course, trained first in animals, and you see here in a video where we punctured right through the left ventricle of the heart of this pig, and performed a through and through device into the aortic arch of this pig. This was our first team who performed this, and very shortly after this, we were able to perform our first in men using transapical TEVAR access, and you see this patient already 12 hours post-operatively, and showing the main advantage in comparison to open heart surgery here. Well, if we come to the aortic arch, we were able to face and use branched stent grafts. Inner and outer stents both have their certain advantages and disadvantages, and also here we were able to perform the first procedures in men, and this is a second prerequisite and advantage of having such a center. We were able to closely connect and collaborate with the world's most important aortic centers, and we were happy to perform this joint study using these endovascular means to treat the aortic arch by endovascular means. However, we also faced specific problems following those procedures, which is stroke following TEVAR. We faced an incidence of roughly 10%, which has the same amount following after open surgery. However, our procedures are having different reasons for this this specific and devastating complication for the patient. And as you can see here in this angiography, we see the air bubbles going up into the trunk and into the brain, who are mainly responsible for those strokes. And in our lab research, we then found out that these air bubbles are set free by setting free our devices. You can very nicely see this here in this video. In addition to this, we then developed an opportunity by introducing carbon dioxide flushing techniques to prevent this devastating complication for the patient. And in our first series containing 36 patients, we at least were able to diminish the stroke incidence from roughly 10% down to 3%. I now come to the thoracoabdominal part of the aorta, And here again, we see we have specific problems associated with Crawford open standard approach, as well as complex branched EVAR excesses. The main burden of both techniques is risk of spinal cord ischemia, which is a problem which was still not solved, besides other serious complications, of course. So this brought us into the opportunity to invent a new idea, coming again from a new technology, the frozen elephant trunk from heart surgery. Our idea was to use and produce a reverse modified frozen elephant trunk for hybrid repair of the thoraco-abdominal aorta, using it just vice versa. We tried different stent graft designs and developed for a period of 10 years with Terumo Aortic to avoid aortic cross-clamping, avoid thoracotomy by using this central stent part, avoid extracorporeal circulation, and therewith reduce the risk of spinal cord ischemia. We again performed a couple of animal series with using this technique and compare it with standard Crawford approach. As you can see here, we used a very sophisticated method to measure the effects of this new device. Here you see an intraoperative feature out of one of our pig animal studies. And our results out of the animal studies was that there are certain and very clear advantages for using this new technology, especially for spinal cord perfusion. And I can tell you that we just last week, 5 days ago, we performed the first in-man procedure using this now called ThoracoFlow device, and the patient has a very smooth and uneventful postoperative course, and this technology was very nicely to be used in men. I come to my final point, the abdominal aorta. As we can see here, abdominal incision defects following open AAA surgery are a major problem for many patients. We have encountered 20 to 30% suffering from this late complication, which never was introduced in our current guidelines. However, following this specific condition, there was an idea to introduce a prophylactic mesh augmentation for the abdominal wall to prevent this specific condition. And within a German multi-center study using this technology, we were able to demonstrate a benefit over a 48-month follow-up using this onlay mesh graft technology. This study and others finally counted to the introduction of recommendations in the current guidelines from ESVS and also the German aortic guideline, specifically that in patients treated for abdominal aortic aneurysm by open repair, prophylactic use of mesh reinforcements of midline laparotomies may be considered for patients at high risk of incisional hernia. So, ladies and gentlemen, and dear colleagues and friends, please let me conclude now. Specialization overall and generally can lead to innovation. Translational research can be key for new paths. This needs a focus on dedicated specialists. The specialist herself needs a 100% focus in an adequate environment, and this finally can lead to visibility and clinical growth. This is here the growth of our new cardiovascular center. We hopefully can start working in 2 years. And I would like to use this opportunity to thank the entire team. Sabine Wipper, who was one of the fellows in our team, now turned to go to be the chief and chair of the University Clinic of Innsbruck Vascular Surgery since 1 year now, and very successful here in introducing advanced aortic technologies. Thank you very much for your kind attention, and I'm happy for your comments and questions now.
Thank you, Professor Bubbas. Do you have any questions from the audience?
Yes. Well, we have some time. You could question every, not only Professor Bubbas. Do you have any comments? Yes, please, Dr. Perineal.
Hello. My question has to do with Professor Gerulakos' presentation. You showed equal results for both open and endovascular repair, but this requires that you have a good volume to achieve these results. So in the Greek reality, how does this apply? Somebody to be competent to produce the results needs to have a good volume. So how do you think we should move forward into achieving these volumes, good results, either with the TEVAR or with the open repair of these complex aneurysms?
Well, I think for both technologies, advanced endo and open repair, it definitely needs centralization. And it needs centralization into centers containing cardiology, heart surgery, and vascular surgery, because all the three specialties need to work very closely together, not only for the procedures themselves, but also for the pre and post-operative course, where we need a very close interaction. We face a difficult situation in Germany, as merely every center is performing aortic interventions and surgery on aortic diseases. And we try to politically force centralization for these specific conditions, which is of course hard to do. But I think a dedicated team with producing dedicated research and publications here will help to move in a natural way towards creation of those centers.
Thank you, Professor Bubbas. I think a key word that you use in your statements, which is really a key word and hasn't been said by others, but we all know that this is a fact, is the centralization leads to innovation. And this is a key statement that is not emphasized the way you did it. Indeed, without centralization, we can't have innovation, we can't have good results, low mortality, low complication rate. I think this is something we'll have to remember. And centralization in many countries is centrally driven by the Department of Health, where we can't take this initiative on our own, because the hospitals we work are state hospitals, not private hospitals. So it needs to be driven by the Ministry of Health or the appropriate authorities of the countries. In Greece, it hasn't happened yet. We hope it will. Thank you.
Thank you.
Next question, yes, Professor Bubbas.
Oh, it's okay.
I have a question to you, George Gerulakos. Thank you very much for your presentation. You showed us the best of the literature. To my view, either from the retrospective or prospective registries, there are problem with the selection bias. And of course, every section must have some selection bias, because if we come to the EVAR2 trial and we do all of these patients, will have an increased mortality. So is the key point now, either for open or endo, to see how much the method suffers and who patient can tolerate any of the procedures, because I think in a series of 8 or 10% are extremely high and maybe not ethically to continue to do that based on the physical history of pararenal aneurysm. So my point is it the right time to see by multivariate analysis which group of patients at the time cannot tolerate endo or open, so as to keep down the mortality and then have excellent results without so increased mortality?
Was this a question towards me?
No. Look, he can also. It's a general question.
Professor Bubbas, it's a question for Professor Geroulakos. But if you discuss something, of course you can.
Yes, you can make a comment before my answer, Professor Bubbas. We're interested to hear your views, and I think it's a general question. It's not just for me.
Yeah. Well, there are quite a lot of data published in the literature concerning the need of centralization of AAA treatment. And I see Henning Eckstein here sitting in the group. He published a lot of data coming from German insurance or statistical claims, showing that EVAR procedures obviously can be done in barely every center. However, it needs dedicated experience in terms of center structure for open surgery. However, as we usually need to offer both technologies for those patients, it doesn't make sense to separate those techniques into different centers. So overall, I think also for straightforward infrarenal aortic disease, centralization is recommended.
Professor Eckstein, welcome. We're delighted to have you in our audience and in our faculty later. If you want to make a comment, please feel free, and I could also say a few words after that.
Yeah, thank you. And hello, everybody. Thank you for the invitation. I don't see Christos Liapis. Is he in the room or in the audience?
He's in the audience, that's why.
Okay.
I can't see him.
Okay. Because, I mean, this symposium is also about to celebrate his, lifelong work for vascular surgery all over the world, in Europe, and especially for Greece and in Athens. Coming back to the question of centralization, the answer is simply yes. First, it doesn't make sense to do EVAR, for example, in one center, but not open surgery. So the selection will always be biased, and EVAR treatment will be overdone a little bit in all likelihoods. One more point is so important. It's not only the lower complication rates or the better complication management, it's also training. I mean, how should we train vascular surgeons in the future if they are not able and not trained properly to do a AAA surgically, open surgically, and endovascularly, if it's done in separate centers? And this is really bad for our specialty. And I mean, we are, if anybody calls a vascular surgeon, patients and referring doctors expect, that's correct, they expect that we are able to handle AAAs, to screen them, to follow up them, to treat them conservatively, and to do the control examination after EVA or after open repair. This is our job, and we have to do everything to bring all the competencies together. There's no doubt about it. And it's nothing that we need centralization only for thoraco-abdominal aortic aneurysms. No, we need centralization for the treatment, conservative, surgical, endovascular for aortic diseases, as Sebastian Debus pointed out.
Yeah, this is also our view. I think it's very important to have patients treated in centralized high-volume centers. You will have to remember that these are complementary techniques. They're not competing with each other. So when they go to a dedicated center, the center should be able to offer all the options. It's not only one option, and then it has to go to another center for a different option for the same disease. It doesn't make any sense. Yeah. However, Professor Eckstein, I point out to you that if you have a look at the publications in France, and France is a country with a great contribution to endovascular techniques for complex surgery, both the publication of Jean-Pierre Bekeman and the publication of Professor Hollon, who were pioneering the endovascular techniques for complex aortic surgery, they used controls for open surgery for different centers. As you know, these publications used controls for open surgery from Rome and from the Mass General in the United States. So that implies that although we publicize the need and the importance to have a dedicated centers provides the full spectrum of techniques, even in pioneering centers in Europe, I'm not sure if it happens along the lines you mentioned, but this is only an observation. Unfortunately, we don't have these pioneers here to give their point of view. But for us who read the literature, it's inevitable to make this comment when there is such a discussion.
Well, I can tell you, just to give you some more information, the in-hospital mortality rate for women in Germany all over the country is above 6% in non-ruptured AAA. And if you look at elderly patients, it goes up, I'm talking about open surgery, goes up to 9 to 10%. So this is almost a situation where you could say, well, don't treat women with AAAs. If you are not very sure that you have a good team, good surgical team, good anesthesiological team, a good ICU, etc., cardiologists nearby, etc., etc. And this is the case. I mean, we're not talking about the 60-year-old man with a 5.5 centimeter AAA with good necks, etc. We're talking about the fragile and the patients that are vulnerable, also in terms of bad outcomes if we just treat them conservatively, especially women, for example. We have a higher rupture rate, so especially women needs to be treated in high volume centers by high volume surgeons, of course.
Thank you very much. I'm afraid we'll have to stop now. We have a break in Athens on the second part of the meeting. Thank you very much, Dimopoulos, for chairing. And the other chairmen, Dr. Hamayourakis and Professor Dr. Malthesis.
Thank you very much, Professor Geroulakos. Thank you, everybody.
Have a good day. Thanks.
Okay.